Thank you very much for the introduction, and also thank you for the invitation to come and speak to you all today. So I'm going to share my screen and hopefully this will work because it worked a few minutes ago. Hopefully you can see my slides okay?
Yes.
Brilliant. Okay. And if anyone does want to interrupt, do feel free. I'm happy to take questions as we go, in addition to the discussion at the end. I've got lots of slides, but it's more important that this is useful and helpful for all of you rather than just me talking at you for the next 40 minutes or so. So what I thought I would do is start off by talking a little bit about some of the sort of trials and pitfalls and challenges that we've had using data over the years, talk about a number of the different ways in which we've tried to overcome some of those, and then provide some very specific research examples for sort of fun or more interesting things that we've been able to do once I felt that we understood the data well enough to be able to do things of high enough quality to be able to answer research questions. So just to sort of start and make sure that we're all on the same page, essentially what I'm going to talk about and provide examples from is routinely collected electronic healthcare record data, which we collect as part of the NHS. And the sort of standard definition for these sort of data, or any data that's collected automatically by a learning object distribution system, and anything that we use for health and or social care. And if you think about the healthcare system in the UK, we're actually phenomenally lucky with the enormous volume of data that we're potentially able to access in order to study a whole host of diseases, be that across primary care or secondary care, a number of very specific disease registries or audits, which are now being linked with more routine sources of data to provide added granularity, in addition to being able to answer more pathway type research questions, right down then to the more nuanced systems that exist within hospitals. So I spent 4 hours this morning doing my EPIC training because we're introducing EPIC into the Brompton. I can't say that I'm any clearer about how it works after 4 hours, but that might be a me problem. As my daughter would say, but you can get very detailed information then from those around vital registrations, things that happen within the nuances of hospital, well beyond hospital episode statistics data. And if I were to think that there's going to be a revolution in healthcare data in this country going forward, I think it's going to be our untapping of some of the granularity that we're ultimately going to be able to get from secondary care systems going forward. And then also very usefully, we have a lot of public health surveillance data, so be that virus data, bacteria data. I won't steal my own thunder and start talking about COVID-19 now, but it would be remiss of me not to from a number of different angles later on. So I certainly will. But we are in a very unique position in this country in terms of being able to access and use data, and really are envied by a large number of countries across the world who are not able to link things together in the way that we can link things together. So I think it's important not to underestimate what we can do. However, you have to be balanced. And as much as I love data, and I don't think we use it enough, and I don't think we do enough with it, there are absolutely some fundamental issues. There's relatively broadly a kind of lack of understanding. People don't see the benefits of the data. They don't understand the coding of the data. They full stop don't understand the data. And that's not just policymakers or government. It's also the clinicians who are ultimately entering the data into the NHS systems to begin with. I can't tell you how many clinicians I talk to that say to me, well, I don't know why you bother, HES data is inaccurate. And then I point out that the only reason the HES data is inaccurate is because they write things down inaccurately, and then the coders don't know how to code what it is they've written down. And you've got to start somewhere. But if we actually put some time and attention into the data to begin with, then actually we'd have an even more robust resource. And I know that other universities are doing this, but one of the things that we've done here at Imperial is start to introduce some teaching around routinely collect electronic healthcare record data to the medical students, because if they're the ones who are ultimately going to be using the systems and entering the data going forward, I think it's absolutely imperative that they understand how the data are used. And the other sort of big issue, I think, around all the data is that the systems don't talk to each other, be that across primary care or across secondary care. So I'm in the, I guess, fortunate position of having 2 honorary NHS contracts. I work both at the Brompton and also Imperial NHS Trust. And at the Brompton, we're just about to introduce Epic, so I've done that. At Imperial NHS Trust, though, we use Cerner, and when I do my community clinic, sat in a primary care surgery, I enter data straight into System 1. And none of these systems are easily able to communicate information from one to the other. Things are moving forward in that field, they are getting better, but I think that's another huge disadvantage that we have at the moment, is around linking up the data. But sort of negatives aside, and whether we like it or not, these data are being used for a phenomenal number of purposes. And this is another thing that I think particularly clinicians don't really have a good handle on. Whether it's using audit data to be able to compare what's going on in your particular locality with other environments and understand if you need to think differently about planning services or resource allocation, or whether it's just about understanding disease trends and epidemiology of what's happening with RSV this month, for example, or why are so many people off sick. Flu vaccination would be another one for healthcare staff. More and more, NHS England certainly are starting to appreciate the value in these data and how they can potentially be used going forward, not just to benchmark services, but to be able to understand how they should be allocating resource and where they need to be able to think about doing things differently. And that might be thinking about underlying populations and basing that on ethnicity or deprivation or other factors that we think may actually impact how resources and allocations are used in particular areas. I'm going to provide a number of examples talking about CPRD data. And before I sort of launch into COPD as my main disease to sort of start with, I assume a lot of you are very familiar with CPRD data. And in fact, this slide is slightly old with respect to its numbers, but I still think in terms of granularity and quality of primary care data in the UK, this is my go-to when it comes to analysing data. I am aware that there are other databases available, and I'm happy to chat later about what I think the pros and cons of some of those other databases are. But for me at the moment, when it comes to analysing something in primary care, this is very much my go-to. And that's because of the really the underlying quality and structure of the data, the relative ease in which you can use the data, and the way in which you can search coding browsers and data dictionaries to be able to create your code list to begin with, to be able to understand the populations of interest and study. And of course, it is linked with a number of other different data sets, as a number of the other primary care data sources are. So what I thought I'd do is I'll talk about a number of different respiratory diseases. I'm going to start with COPD because this was really what I started with in terms of looking at the data. And many years ago, when I was first a postdoc and had a population health scientist fellowship and was based at London School, one of the things that I realized was that if I was going to spend the rest of my life using these data, I really needed to understand the data and the coding. So early on, it became quite apparent that the quality and outcomes framework, as good as it is for what it does, is absolutely for COPD not a disease register. And yet it's what people have been for quite a long period of time using to try and understand what a COPD population looks like. And I would argue that a number, if you just look through the code list there on the right-hand side and look at some of the specific codes, chronic tracheobronchitis or bronchiolitis obliterans are absolutely not COPD. And from a respiratory standpoint, I know that. And so I would never want to use them in a code list if I was defining a population of people who truly have a diagnosis of COPD. So one of the very first studies that I did was to try and validate how to identify a population of people with COPD from routine healthcare data. And my PhD students will tell you that they pretty much all get some sort of validation or data methodology exercise whenever they do a PhD, because I think understanding the nature of the data is exceptionally important if you're going to use it Saying that, these studies are very expensive to do. They're becoming harder to do because of being able to access people and issues around data privacy, which again, we can talk about later. And they cost an enormous amount of money. So you certainly can't validate absolutely everything that you're going to do, but I think it's really, really important. And there are ways that you can do validation without having to send questionnaires out, which can help. But in this particular instance, we came up with a number of different algorithms, ranging from being really quite loose to just having respiratory symptoms or just having a COPD code, right through to having a code and the presence of spirometry and the evidence of being treated for COPD in terms of our algorithms. And we, through CPRD, sent out questionnaires to GPs and asked them a simple question, having determined a list of individuals relative to these different algorithms. Did they think that this individual had a diagnosis of COPD or not? What did they base that on? And was there any other confirmatory evidence that they could send us? And what was really interesting to come out of it, for me anyway, was that actually a COPD code on its own had a similar PPV to going through all the rigmarole of determining, having evidence of medication and spirometry, et cetera, And I won't go into detail, but we did several other spirometry studies following on from this. And one of the things that we quickly uncovered was that if you actually looked at the tracings of spirometry can be done very high quality within primary care and very well. But the interpretation of the spirometry was not always necessarily as accurate. And so if you look at raw readings within the data and you're calculating somebody's percent predicted FEV1 as we would do for COPD, you can do that quite accurately from the raw data. But that if you're relying on somebody's interpretation of the spirometry, because that's perhaps not as good as it should be, it doesn't really add a huge amount in terms of validity. And you can increase the size of a COPD cohort by over 10% by simply using a code and not looking for the evidence of code and spirometry. And there's very good reasons why you might want to use several of these different definitions, depending upon what your study question is. But certainly there's a specific list that we would always use if we're trying to determine somebody with a COPD diagnosis. Slightly more fun then was trying to determine an exacerbation of COPD. And this was more fun for a couple of reasons. So one, clinically, we don't really know how to make a diagnosis of a COPD exacerbation. It's a diagnosis of exclusion. So it's not like having an acute heart attack where it's very clear and there's a biomarker, etc. This is very much a, what do they not have? Then you sort of assume if somebody comes in breathless with COPD that this must be what it is. So that makes it much more complicated where there's clinical uncertainty to then try and layer on top of that all of the coding uncertainty. But similar to the previous study, we came up with a number of different algorithms to test, based partly on what other people had done before in the literature and partly based on clinical knowledge. And here we did something a little bit different. We sent out questionnaires to GPs again, but this time based on our algorithms with very specific dates, and said to them, do you think the patient had an exacerbation on these specific dates? And then married those up against our algorithms. One of the really nice things about this particular study was this was back in the days when we were able to access the free text. And the additional value of information that you can get from free text is absolutely phenomenal. And although at the time going through over 1,000 COPD patients' records for free text felt a little bit painful on occasion, it was well worth it. And the amount of additional information we picked up, superb. So I would like to think that going forward, we're going to be able to find a way that we can better use some of these free text data again and be able to counterbalance some of the issues around data privacy. So from this, we actually came up with a combination of algorithms that we would suggest that people use to determine an exacerbation. Again, slightly depends upon your study question. Do you want to be more inclusive, or do you want to be absolutely sure that somebody's had an underlying exacerbation event? And then we thought, well, it was worth having a look at the linked data and with HES. So I'd always been told everything ends up in your primary care records. You don't need to have linked data and have HES data. You can determine everything purely from primary care. And what became quite obvious to us was two things. One, that if you didn't use linked hospital episode statistics data with the primary care data, you would underestimate in each individual patient the frequency and the severity of the exacerbations that they have. And a number of people have looked at this from various different angles. Lizzie Millett did a study many years ago when she was at London School, looking at community-acquired pneumonia, and showed that actually if you only use the primary care records, you underestimate the incidence of community-acquired pneumonia. For chronic diseases, I don't think it matters so much. Things ultimately make it back into the primary care record, but for acute events, I think that linked data is absolutely paramount. The other thing that we tried to understand a little bit of was how people code and why they code in hospital in particular ways, so that we could determine the best way to pick up an exacerbation event rather than picking up a pneumonia event. And again, using the linked HES data, we're able to come up with strategies that we recommend that we've ultimately gone on to use for the National Asthma and COPD Audit Programme going forward. So whilst a lot of people think that the methodology stuff is quite boring, actually, I think it's exceedingly interesting. But once you have established what you're going to do and how you're going to do it, you can then go on and start to answer some slightly more fun research questions. And I'm just going to run through a few examples of the sorts of questions that we've been able to answer. So this was simply looking at time to death based on people's underlying exacerbation frequency. So these were prevalent COPD patients going to their GP and being able to look over the 10 years of follow-up, how that was associated with an increased risk of death. The kind of study that you can't do prospectively really without spending long periods of time or answer using trial information, but incredibly helpful in terms of how we might manage people with COPD in primary care. We've gone on to do quite a bit looking at cardiovascular disease amongst people with COPD, given their increased risk of cardiovascular disease. This was done by Anne Morgan in my group many years ago when she was doing her PhD, simply looking at cardiovascular diseases relative to a general population and looking to see if the incidence of these cardiovascular events had changed over time relative to the general population. And what we found is that even over time, people with COPD, although they have an increased risk of all of these particular outcomes here, she went on to show that they're less likely to have a diagnosis and more likely to have a delay in their diagnosis. We've done quite a lot of work subsequently looking at medications, and this is work that Eleanor Axon had done in my group when she was doing her PhD. And here we were exploring COPD exacerbations in people with heart failure and COPD relative to their management of their heart failure. And what was interesting with this particular study was essentially ascertaining that people who were likely to have heart failure, so possible disease but not a formal diagnosis, were at increased risk of COPD exacerbations. And then when actually they were treated for their heart failure and had a diagnosis, compared with being a possible heart failure diagnosis, they actually had fewer exacerbation events. So again, that kind of goes back to the point I was making earlier about some of the uncertainty around making a COPD exacerbation diagnosis, and the fact that actually if we have other diseases that have overlapping symptoms and we're managing them and the exacerbation rate goes down, that says to me that maybe not all of those exacerbation events were true exacerbation events. And then Hannah Whitaker, as part of her PhD, when she was in my group, went on to look at cardiovascular risk by a number of different factors. So looking at lung function, fast and slow decliners, as well as exacerbation severity and dyspnea, and showing again that there are certain subgroups of people with COPD who are at increased risk of cardiovascular outcomes. When Claudia did her PhD with me, we actually looked at using some US data. And so these are data from the Optum Labs in the US, which is part of one of the large healthcare insurance providers. They have access both to the administrative data as well as in a subgroup having actual EMR data. And we've also in the past used the National Inpatient Sample data from the US. Very, very different in terms of the structure and setup and also the problems associated with using the data. But in this particular analysis, Claudia was looking at a group of people who had heart failure and using a latent class analysis to try and understand, are there subgroups of people or clusters of certain comorbidities that then influence people's outcomes. And the main reason we did this is that we had the hypothesis that there would be a very COPD specific group, but in fact that wasn't what we found. And you can see the various different groups together that we did see there. I mentioned earlier the importance of some of the audit data sets. As much as I love cardiologists and cardiology, one of my real upsets early on was learning that the MINAP database only had an obstructive airways disease variable and not any sort of differentiation between COPD or asthma, which is incredibly important because how we manage them and how we manage their cardiovascular disease may well be different based on issues around using beta blockers in people with asthma that don't exist in people with COPD. And one of the early pieces that Kieran Rothley did when he was doing a PhD in my team, he looked at how we can, using a subset of the MINAP data linked with CPRD, derive an algorithm to determine who has COPD within MINAP relative to who would have asthma. And then from that, we were able to go on and explore some of the depth of COPD outcomes using the MINAP data. Then from that, Varun did a piece of work using the MINAP data where we were looking at peak troponin levels amongst people with different underlying comorbidities. One of the things that we found is that if you have COPD, your peak troponin level after having a heart attack is not as high as somebody without COPD, which is incredibly interesting from a research and answering questions standpoint, because there's a lot of concern that elevations of troponin when somebody has an exacerbation of COPD are actually simply because they've got an exacerbation of COPD. And what this work questions is actually, are we missing an opportunity and missing potential cardiovascular events that we could be intervening and treating earlier on in the course of people's disease? So those are my COPD examples. I'll run through a number of examples for asthma and then move on to a slightly more complex respiratory disease. So these data are old. In fact, we've got more recent updated data, but I just wanted to highlight here some of the importance of appreciating the definitions that you use, and that the problems with asthma are not dissimilar to the problems that we had with COPD. So there are over 80 odd codes that you can get within the primary care records to indicate that somebody has a diagnosis of asthma. This is what happens if you use quite a restrictive list. And this is what happens if you're trying to look at an underlying population of people who may have a diagnosis of asthma, which is something that we were asked by Public Health England back in those days to look at. And actually, we never published this because I said this is just wholly inaccurate for a whole host of reasons that I've already alluded to. And I wasn't happy that you could determine a missing population of people with asthma based on these sorts of data. So one of the things that Francis Nissen did when he did his PhD was to validate how we might truly find a diagnosis of asthma within the databases. And again, similarly to the COPD analogy, we came up with a number of different algorithms, sent questionnaires out to primary care, and then we're able to look at how best to do that. And similarly to those results, we were able to show that actually you can just get away with using an asthma code and not necessarily have to go through all the rigmarole of finding codes for reversibility testing, etc. And then from all of this, updated the prevalence and actually found that the prevalence was a lot lower than what people had been quoting in terms of asthma disease prevalence. One of the things that Francis also went on to do was to say, well, okay, when we look in secondary care at people with asthma, we often think about them in terms of different underlying phenotypes. Can we take some of that work and can we project that into primary care and potentially find people who are of various different phenotypes based on data that are routinely captured? And what he found is that whilst you can absolutely establish your own phenotypes within primary care in a general asthma population, a lot of them didn't fit into these phenotypes, which are predominantly studied in secondary care. And I think this also is really important because if you think about a disease like asthma, where the majority of it is actually looked after in primary care and very few people make it to secondary care, what we often gets published about or worried about is the tip of the iceberg and not the overarching underlying patient population. We've also then gone on to look at management and care of disease. So looking at things like asthma annual reviews, asthma management plans, action plans, inhaler technique, and trying to better understand how well these things get coded and recorded within the data, allowing us then to be able to ultimately go on and look at patient management. I mentioned earlier that we've updated some of the incidence and prevalence work. This is actually a pediatric asthma population, but interestingly, the incidence of asthma is absolutely decreasing over time in a pediatric asthma population. What is increasing, though, is their exacerbation rates. And I think that this is very much a good news story, because what it says to me is that we're not labeling people with a chronic disease diagnosis unless we're more sure that they have a chronic disease diagnosis. And so therefore, those people that do have a diagnosis are the ones that are appropriately using healthcare or exacerbating. And I'm sure a lot of you will understand the pain of trying to understand prescription data within the databases. So I just thought I'd put this in around GeneSteps, which is a way in which we look at asthma severity and which is determined by using prescription medications. And it cost us and Anne probably a good 4 months to be able to write all the code to determine how we were going to pick up prescriptions to be able to determine the GeneSteps within the data. And this is certainly something that we are going to put as soon as the paper is published in the public domain, because I think the learnings and the transparency around this are really, really important. Not to say that you would always do a study exactly the same way. Sometimes there's very good reasons why you would make subtle changes to things, but I think that transparency of reporting when using these data is absolutely paramount and not something that as a community we are particularly good at doing. So asthma and COPD being relatively common diseases were pretty straightforward to try and get to grips with within the data, and hopefully you're kind of coming up with analogies around the types of chronic diseases that you're looking at within the data. What's been much more challenging for me is trying to understand interstitial lung diseases within routine data. And this has been for a number of different reasons. So one, it's not a particularly straightforward area clinically. IPF physicians or interstitial lung disease physicians have a really bad habit of changing how they classify things on a relatively frequent basis. I don't know if they do that to keep us standard respiratory physicians on our toes, so that we constantly have to keep referring to them, but they are constantly changing the nomenclature and the way in which they change these things, which again then makes it really difficult to try and track if you're looking at things long term in the data. So whilst we've been doing this particular piece of validation work, one of the things that we've looked to try and understand is how has that coding changed over time? And this graph is just a really good example of showing how one particular code was very much taken over by another particular code around 2011. And if you didn't know that about the data and you were just using what you started with, then you risk having a bias in terms of your results of your study. And there was a beautiful COPD paper actually that was published many years ago now, where they were looking for opportunities for missed COPD diagnoses earlier on in the patient's records, where they fell exactly into this trap and basically were measuring people against codes that didn't exist and weren't used in the 20 years prior, and missing what we had called COPD back in the 1980s relative to the 2000s. So understanding how things are changing over time is extremely important. And I've already alluded to the importance of understanding the overlap between databases and concordance between databases. So I'm just going to talk briefly about mortality before I then move on to COVID-19, because the ONS data, again, comes with its own special challenges, as much as I love the ONS data. One of the things that we wanted to try and better understand, and this is what Alethea Gale had done when she was working with us, was what people with different respiratory diseases are dying of and how that's changed over time. And the underlying cause of death relative to how things are structured in ONS seems to be a reasonably accurate way of trying to determine somebody's underlying cause of death. With the caveat, of course, that, if you take COVID as an example, people change where the goalposts are in terms of what's determined a specific cause of disease death over time. And also the reasons that people code, or the things that they put down sometimes in the underlying cause of death, so the part 2 of the death certificate, can still be incredibly informative. So how you use the ONS data, I think, is very much dependent upon what the question is that you're trying to answer. But essentially, we wanted to look at what people were dying of and how that had changed, particularly over time. And one of the things that you can see here, and this is just looking relative to the general population in particular, is the reduction in asthma deaths that there have been over time, but with a relative increase in some of the other respiratory diseases. And I haven't put the detailed slides in as to the changes in the causes of death, but there have been a number of changes in terms of causes of mortality over that time period as well. So I think you'd probably all agree with me that whilst there were many awful things about the COVID-19 pandemic, one of the good things, if we're trying to find silver linings, is the ease with which people were then able to access data as a result, and the appreciation of some of the importance of data and how you can answer some really important questions quickly. I think my only hesitation would be that certainly everybody I speak to now seems to think they're a respiratory epidemiologist, which I would question, albeit politely. I think there has been quite a lot that has been published that maybe hasn't had the same scrutiny that other studies in the past have had. And I think there has to be cautious interpretation of some of the things that have been published using these data around the COVID-19 pandemic. And that's not to say that people are, deliberately doing things wrong for a particular reason, but I just think, it's important to be cautious. So I took the decision actually very early on in the COVID-19 pandemic that I wasn't going to try and make my career out of this, as I was very aware some people were, but instead I was happy to help anyone who asked for help. And it's quite frightening actually, now sort of looking back and appreciating how I ended up as a middle author on literally 40 or 50 studies over the last couple of years, simply from helping people out around the data, which, and if I felt if I could make a study of a higher quality and better, then that for me was more important than trying to get a massive publications out of it. One of the things that was really difficult early on, as I'm sure you're all aware, was trying to work out who should be shielding or for COVID-19, and then amongst that, who should be prioritised in terms of vaccination. And what was fascinating was looking and working with some of the people with some of these early studies and things that government had on their list. So their early list for chronic respiratory disease actually had extrinsic allergic alveolitis on it. And I don't think we've clinically used that term for about 10 years. And actually, you wouldn't pick anyone up in the primary care data if you looked for an extrinsic allergic alveolitis code. So being able to say to people early on, actually, this is what you need to be looking at. And this is how, if you're going to use the primary care data to be able to find people for vaccination, etc., these are the code lists and the things that you want to be thinking about using. And I was really lucky to work very closely actually with a lot of different teams at London School around all of this. This was a piece that Anna Schultz had done using the Open Safely data, looking specifically around the question of inhaled corticosteroids and whether they increased or decreased your risk of COVID, because there was a lot of noise early on about whether or not they might be protective in some sort of way, but a lot of confounding by respiratory disease severity, as I'm sure you can appreciate, and often very difficult to completely negate all of the confounding. One of the other interesting things that I felt or learnt around the pandemic was some of the tension between policy and government and people trying to really make sure that certain diseases were heard about or thought about a bit more. And there was a lot of controversy around asthma itself being a risk factor for COVID-19. And in fact, some of the early studies around chronic respiratory disease that specifically looked at wave 1 were completely biased in terms of their results because of the selection bias that there was in terms of people who were tested to begin with when we didn't have routine testing. And I think the best studies that have sort of looked at general population or underlying disease cohorts are those studies that looked from wave 2 up until the point that we stopped testing so regularly, because you really needed random samples and significant general population testing to be able to truly understand whether there was significant risk. And this was a nice piece of work that was done in collaboration with ONS, trying to understand if people with asthma were at increased risk of worse outcomes. And we found that actually they were not. So this was done using linked census data with ONS mortality data and the hospitalization data. And essentially in both children and adults, what we were able to show is that if you have well-controlled asthma and you don't have severe asthma, then actually your risk of adverse events is no higher than the risk of the adverse events in the general population. And this really was quite a turning point and very important, because then it said that a lot of those people with asthma who were being told to shield really didn't need to be shielding anymore. And then also, I think where the primary care data came into their fore was being able to look at GP consultation rates and starting to understand a little bit about what were people going back to their GP with post-COVID in terms of trying to understand a little bit more about long COVID. One of the newer data sets that we've gone on to use is the NHS digital data through the BHF Cardiovascular COVID Impact Consortium, and using the linked GP data there for pandemic preparedness, linked with HES and ONS data. And this is some analysis that Hannah had done, trying to understand if people with COPD, asthma, interstitial lung disease and bronchiectasis were at increased risk of cardiovascular complications post-COVID relative to the general population, and indeed found that in some cases they are, and that this risk is negated if you are vaccinated, which I thought was a really very interesting piece of work. One of my slight hesitations, though, with using the primary care data within NHS Digital is particularly for respiratory disease, the complete and utter lack of granularity around the variables that we would ideally want to be able to adjust for within respiratory analyses. So, for example, there's no spirometry data within that pool of primary care data at all. Or being able to look at asthma control through asthma control questionnaires or things like that. So it's really good for high-level incidence prevalence. It's really good for prescribing data, but for sort of the important respiratory nuanced questions, for the time being, CPRD remains the sort of database of choice. So just finally then, in the last couple of minutes before I finish, I just thought I'd talk a little bit about work that Breathe has done and will continue to do more widely through the HDR UK QQ2 Inflammation and Immunity Driver Programme that I'm co-leading with Aziz. And this work was done collaboratively across Breathe a couple of years ago now, simply to look at how are people coding and recording work associated with chronic respiratory diseases. And you can see from this that, you know, there's no reason that we need to have nearly 250 read codes to indicate that somebody's got a diagnosis of asthma, or that people have used across a number of different studies. And I have to say, this is probably the thing at the moment that absolutely does my head in the most. And I don't understand why we cannot just simplify this and actually all agree on a certain set of, you know, slightly smaller list that we may use for different reasons. But to my mind, there is no need for 250 asthma codes. So one of the things that we set out to do is to try and harmonise and make these available through HDR UK, working very closely with Swansea. Sarah Hattam, who I can see is on the call, has done a phenomenal amount of work. She's been absolutely brilliant, looking at this both within CPRD with my team and also more recently doing some work in the Scottish data in Datalog. And what we've been trying to do is curate data sets in SAIL, in CPRD, in the NHS digital data and in Datalog, so that it doesn't take somebody a year to do a cut and to clean the data, but that we can have already predefined algorithms and variables that somebody can tweak off the shelf so that they can do it in a much quicker period of time, so that A, we're all saying the same thing and defining the same things, so that when we're comparing the outcomes of studies, we can actually say we are both looking at the same disease. And also just to speed up the process of being able to use these work. And I think my favourite piece of research at the moment to underpin this is work that Hannah Whitaker in my group has done, where she took a number of different COPD exacerbation definitions that have been used across the literature, and then just did a simple analysis looking at the association between having heart failure and COPD relative to only having COPD and your risk of future exacerbation events. And what she found is that actually you do get a association or you don't, depending upon the definition of exacerbation that you use. And this, to my mind, just fundamentally illustrates why we have all got to start to standardize how we're using these data and how we're defining our outcomes, because otherwise it makes an absolute mockery of using the data for policy informing and planning and research going forward. And in terms of informing policy, actually NHS England have really taken this on board, as have Asthma and Lung UK, and we're really trying to drive this forward now from a respiratory standpoint and encourage people to use the same definitions. And this is just an example of work that's just been submitted for publication in collaboration with Asthma and Lung UK, where we've looked at the prevalence of COPD based on a number of different definitions. And this is just some of the definitions. But what you can see, although the blue doesn't come out too well, the different shades, the top line there on the right-hand side at 2019 is the validated COPD definition, the one just below that, the QOF definition. And whilst a 1% difference between the two definitions isn't particularly huge, actually those lines are definitely diverging. And so if we're going to think about resource allocation and planning, then what we need to be doing is all talking about the prevalence of COPD in the same way. And also when we come to look at it again in 5 or 10 years' time, using the same definitions that we've used now, so that what we're truly looking at is as prevalent disease. So I'm just going to finish by saying an enormous thank you to my team, most of whom I've shown you some work from today, who are absolutely brilliant, without whom I'd have absolutely nothing to talk about. So thank you very much, and I'm very happy to answer any questions.